Yeah. Very good evening and namaste to everyone. On behalf of Intas Pharmaceutical Limited and on behalf of Intas Zenith, I welcome you all to this very successful live scientific program, Practice Pulse in Endocrinology. And today we are going to witness a sixth chapter of Practice Pulse on endocrinology, and we are going to discuss about the hypothyroidism. And to do so, we have with us two eminent speakers along with our course director, Dr. Subhankar Chaudhary, sir. Dr. Subhankar Chaudhary, he is a professor and head of the Department of Endocrinology, IP Jimmer and SSKM Hospital, Kolkata. He is also editor-in-chief, Indian Journal of Endocrinology and Metabolism. And he is a past president, Endocrine Society of India, as well as past secretary of RSSDI. He is also a member of subject expert committee of CDSCO, Government of India. And he is a founder patron of South Asian Federation of Endocrine Society. And he has more than 170 publications in various national and international journals. It's an honor to have you, sir, on board. Over to you, sir.
Thank you very much. Warm good evening to all of you. Happy festive greetings. Let's hope we gradually wriggle our way out through the COVID crisis. We are seeing some signs of improvement across the country, though there are definitely pockets where the problem still remains. We are really overwhelmed with the response of all of you to this novel program, Practice Pulse in Endocrinology, that has been running every month for the last 5 months. This is the 6th month. And this evening, we have chosen a topic which is very common. Thyroid disorders are the second most common disorder, endocrine disorders, following diabetes. And hypothyroidism is something that we should not miss because treatment is very gratifying. And to take us through the area of hypothyroidism, of course, we have to be choosy. We have a time restriction. So we have two topics this evening. The first is a topic that's sort of comes up every now and then. You do see individuals with just a little bit mildly elevated TSH report, which is designated as subclinical hypothyroidism with the T4 being normal. What to do? Do we treat all of them? Do we treat some of them? Whom to treat? How to treat? That's one part. The other part is a very interesting, a very important area of management of hypothyroidism across different age groups, how we approach what should be the dose. And if, for example, we have someone diagnosed at birth, and then that person goes on to live till 75, 80 years, how does the dose plan change across these different life times? So first things first, we have, and to take us through, as in the previous editions, we have two of the big names in the field of endocrinology in our country. First of all, we have Professor S.K. Singh, who is head of the Department of Endocrinology at the BHU IMS, and has been a big name in the endocrine field. He has actually been the secretary of the Endocrine Society of India over a relatively difficult period of time. Now, of course, it's on a much firmer ground. And then he went on to become a very deserving president of the Endocrine Society of India. And of course, he is a teacher. He's got, I'm sure, his students are now also teachers. So he's a teacher of teachers of sorts. And so we will hear from Professor S.K. Singh valuable words, valuable advice on subclinical hypothyroidism, when to treat. And Professor Singh, maybe you have the floor for about 20 minutes or thereabouts. Thank you very much.
Good evening, everybody, and thanks to Dr. Subankar for introducing me in this webinar. Uh, I express my gratitude to Intas Pharma for giving this opportunity and organizing a webinar on very important, very common problem, endocrine problem, as Dr. Subankar said, after diabetes, the thyroid disorders and particularly hypothyroidism. So we are very comfortable in treating hypothyroidism. It's quite gratifying. But the problem is when it is early hypothyroid or when it is not a frank hypothyroid, then where should we go? The way we stand at the crossroad to decide whether to treat this patient or just to leave it and wait for the consequences to happen. This is the topic that has been given to me is subclinical hypothyroidism, when to treat. I take you to, overall prevalence of subclinical hypothyroidism, that is defined by the free T4 being normal and TSH is above the reference range. So free T4 is normal and TSH above the reference range. That qualifies to be called as subclinical hypothyroidism. These patients may have very subtle features of hypothyroidism, or they may not have any feature of hypothyroidism, yet they have biochemical evidence of slightly elevated TSH having normal free T4. Overall prevalence have been studied from time to time using the different cutoff reference range for TSH, and international prevalence had been 4 to 15%. In one of the enhanced study in 1992, they said that 4.3% of subclinical hypothyroidism. Our national data is suggesting that this could be 9.4% to variable to 11% in women and 6% in men, and average would be 9 to 9.4%. But some of the study, I know that they have quoted even higher figure of to 18% of subclinical hypothyroidism in their study. But that depends on what type of patients they have selected, the age group, the more number of females, and all these will influence the overall prevalence of the disease. But it has been seen that almost 50% or 60% would have uh, evidence of autoimmune thyroid disorders having subclinical hypothyroidism. So that is very important point, that the commonest cause of subclinical hypothyroidism would be autoimmune thyroiditis or autoimmune thyroid disease. But to add to the list of causes of subclinical hypothyroidism, there could be drug impairing the thyroid function, iodine containing or even non-iodine containing drugs, inadequate replacement while treating overt hypothyroidism, frank hypothyroid, some disease affecting the thyroid gland, thyroid infiltration, toxic substances, and particularly the chemical endocrine disruptors, TSS receptor gene mutation, which is again very rare, uncommon, but one can get this kind of situation. Aging, obesity, chronic kidney disease, Addison's disease, where there is a cortisol deficiency, and during the period of recovery from non-thyroidal illness, one could have subclinical hypothyroidism. This is one situation. There is a subclinical hypothyroidism. Free T4 is normal and TSH elevated. But then there could be a situation where TSH is high, and this is not actually exactly a subclinical hypothyroidism. It is because of the error in measurement of TSH. And this can happen when there is a circulating antibody, particularly in rheumatoid arthritis, where there is a heterophilic antibody that might give false picture of elevated TSH. There could be lab analytical error. TSS secreting pituitary adenoma could also be a cause of elevated TSH. Isolated pituitary resistance which is again very rare. TSH beyond reference range, but in normal for individual. And this is particularly seen in elderly people, very aged. They may have TSH on a higher side. Secondary hypothyroid, when there is a defect at the pituitary level, they may have slightly elevated TSH and T3 and T4, in fact, being lower than the normal or in the normal range. Uh, what are the consequences of subclinical hypothyroidism? Usually, they don't have any clinical feature of overt hypothyroidism, but this can progress to overt hypothyroidism. Or there may be increased risk of cardiovascular disease, or there had been a study that mortality data is slightly high in people who have subclinical hypothyroidism. They may have associated non-alcoholic fatty liver disease or mood disorders, neuropsychiatric symptoms, or pregnancy loss. Some potential consequences have also been studied, like in obesity, neuromuscular symptoms, particularly vague pains, aches and pains, Alzheimer's disease, verbal memory and executive function impairment, deep venous thrombosis, common bile duct stones, and refractory anemia, particularly picture of iron deficiency anemia. So I bring this case very commonly seen, a female in reproductive age, referred for vague symptoms, fatigue, difficult to lose weight, and forgetfulness. Clinical examination is essentially is normal, and lab tests, free T4 is normal and TSH is 7. So what should we do in this case? And therefore, we need to know more about subclinical hypothyroidism. If you trace the natural course of subclinical hypothyroidism, it has been seen that 60% of the cases will revert back to normal over a period of 5 years. This is one data. I'm not generalizing it, but then 50-60% will come back to normal. Some very small group may continue to have subclinical hypothyroidism, but around 2 to 5% people will develop overt hypothyroidism over the year. So conversion of subclinical to overt is around 2.5 to 5%. And the factors which are responsible for conversion of subclinical to overt, most important that has been studied is presence of autoimmune thyroid disease or anti-TPO antibody. Now, anti-TPO antibody presence suggests that there would be conversion of 5% to overt. If it is negative, it suggests there would be conversion of around 2.5% to overt. It means that presence of anti-TPO antibody will only say that 5% would convert to overt hypothyroid. But if it is negative, only 2.5% would convert to hypothyroid. So is it justified to order a test of anti-TPO antibody when conversion is 95%, 97.5%? They will become same, they will become normal, or they will revert back to normal. So only for a very small chunk of people who are actually developing hypothyroidism, overt hypothyroidism, we are unnecessarily advising anti-TPO antibody test, and which is very expensive, costly, and that becomes very worrisome to patients when they read the value very high, like 150 unit is the reference range for a laboratory, and when they read 400, 500, they become worried why this anti-TPO, which doctor has advised, is positive. So it is not essential to go for anti-TPO antibody in such cases, and we normally don't recommend. It's better to repeat the test and see what happens. If patient develops overt hypothyroidism or qualifies to be treated, we have to treat. Now coming to a second case, 65-year male presented with chest discomfort, burning in epigastric region, no history of illness in the past. He is a smoker and occasionally takes alcohol, and ECG is essentially normal. TSH was 9, and again, as per definition, this is a case of subclinical hypothyroidism. Should we treat this patient? Suggests that he has some cardiac problem. And now we need to know what is the consequence of subclinical hypothyroidism. As I suggested, that this has been associated with increased cardiac risk and cardiac mortality. So these are some of the very old papers, almost 12 years old, but studied in large number of patients above 65 years of age, 3,000 patients included. And what they have suggested that the heart failure events were more in those who actually had TSH above 10 and subclinical hyperthyroid than those who had TSH between 4.5 to 9.9 or even less than 4.5. So this is the overall incidence of heart failure in those who have TSH less than 0.45, means they had subclinical hyperthyroidism, and it is also increased in those who had TSH of 4.5 to 9.9 and 10 to 20. So they will have higher prevalence of higher incidence of heart failure. But in the reference range of TSH, the heart failure incidence was low. Meta-analysis is needed when this kind of data is there, and there are many more papers and meta-analysis has suggested that there is an association of heart failure and heart coronary artery disease with a high level of TSH. However, those who have age of more than 65, the mortality or the incidence of coronary artery disease was less. It was 1.05 compared with those who were younger than 65 years, it was 1.5. So it clearly means that the high TSH is not that detrimental in people above age of 65, but it may be of concern in younger people. Now, if it is so, now what would happen if they are treated with thyroxine? And Biondi group again has reviewed and published many papers that double-blind placebo-controlled trial of thyroxine therapy had led to improvement in systolic diastolic function of the heart. But the Cochrane review has not given enough evidence that therapy would be of much help in these patients. Some echocardiogram parameters might improve, but overall mortality data has not been improved with thyroxine therapy. However, heart failure cases, as I suggested, that the data is there, and again, that study is quite convincing that they might have problem if they have subclinical hyper or TSH level is quite high. Now coming to another case, 30-year lady referred to OBS and gynae for thyroid hormone profile, and again the TSH was 5 with FT4 normal. So what would be the next test? Here we know that anti-TPO antibody, which is a marker of autoimmune thyroid disease, had been associated with increased miscarriage and preterm delivery, and this can also lead to overt hypothyroidism, and we know that consequence of overt hypothyroidism in pregnant lady. So the recommendations are that there should be a universal anti-TPO antibody screening to help patients preventing fetal loss or abortions. Pregnancy and subclinical hypothyroidism has also been studied, and they have suggested that twofold increase in subclinical hypothyroidism when TSH ranges from 2.7 to 11. So TSH of 2.5 to 5, they have less than 2.5, they have taken as quite convincingly normal in pregnancy, and above 2.5 has been associated. However, this another study has suggested that 2.5 to 5 compared with TSH below 2.5, there was a fetal loss of 6% and 3% in year 2010 by Negro, and actually Negro had studied more on these patients who had anti-TPO positivity with thyroxine therapy. The data has not been very convincing to give benefit to patients for fetal loss. So overall, anti-TPO antibody presence is associated with pregnancy loss, and that is undebatable. That is very convincing. But treating the TSH to below 2.5 and close to 4 is still is being debated. So treatment of pregnant women with TSH more than 2.5 in presence of anti-TPO positive was suggested, and in fact that has been taken up by most of the American Thyroid Association guidelines in the past. However, subsequently the consensus has been that we do not have very definite evidence to support that TSH should be brought to 2.5, or treatment with thyroxine in anti-TPO positive women bringing 2.5 and less of TSH will translate into much of the better pregnancy outcome. Now, presence of symptoms like fatigue, weight gain, impaired memory, and depression, cognitive function, that has also been linked and analyzed what happens to these. And the older papers actually have suggested that there might be some benefit in one paper, and the other paper has given the conflicting data. And Cochrane review has suggested that no statistical significant improvement for symptoms, mood, and quality of life. Only one study is statistically significant improvement in cognitive function, that by Cooper. They have suggested that with treatment there was improvement, but then subsequent data analysis has not shown statistically significant improvement in these parameters with thyroxine therapy. This is another information that the LDL level increases with the increasing quartile of TSH. At the TSH value, the LDL level increases. Now, this is also very important. It means that hyperLDLemia can be associated or can be contributed by subclinical hypothyroidism, and thyroxine therapy might be helpful. And they have also found that the thyroxine therapy has led to decrement in the total cholesterol. And the Cochrane review study have again shown this information, that the treatment has led to improvement in LDL, but it was not very significant in all these studies. In some of these studies, there was a significance, as you can see in Nestrom study, it was significant, but other study, the significance was not reached with thyroxine therapy. So that is another point to be debated. However, some benefit may be given to your patients when, in spite of lipid lowering therapy, LDL is not brought down, one would think of adding thyroxine to these patients. CKD and TSH. This is another very interesting observation, that people who have little elevated TSH, which again could be an effect of renal failure itself, but when it is treated with thyroxine, they found that eGFR or decline in GFR was slowed down. So therapy had been beneficial in this study, and now they say that the TSH should be normalized in people who have CKD, chronic kidney disease. Not very recent, a year old, this data from B&J rapid recommendation on treatment of subclinical hypothyroidism 2019. And what they have said that there had not been enough evidence to support thyroxine therapy in subclinical hypothyroidism except pregnancy and younger people less than 30 years of age, or TSH is more than 20. TSH more than 20 with T4, FT4 normal, they say that they can be treated with thyroxine. Otherwise, thyroxine therapy is not recommended by them. But these were some of the experts. Not they have not been the experts of various trials, but they have been expert of endocrinology, and they have made this recommendation that therapy is not useful unless patient is young, pregnancy, or TSH is more than 20. And there have been concerned that 20% will become hyperthyroid if you are very enthusiastic in treating subclinical hypothyroidism. In Cochrane review, 4 study reported adverse events. Some patients felt worse and they were not benefited, and some of the cases of angina, atrial fibrillation. So that should also be remembered while treating. So just to summarize all these data and information conflicting about the treatment of subclinical hypothyroidism, I think we should take this message that we have to uh, group the patients into two: less than 65 and more than 65. Less than 65 up to 4.4, the treatment is 0.4 to 4.4. Consider treatment with levothyroxine in multiple symptoms of hypothyroidism: positive anti-TPO antibody, progressive increasing TSH level, and planning for pregnancy, or patient has goiter. They may be treated. It's not necessary that they should be treated, but particularly in women, positive anti-TPO antibody, progressive increasing TSH, and planning for pregnancy, presence of goiter. Otherwise, more than 65, treatment is not recommended. 4.5 to 6.9, again, this is the points one should take in mind: that multiple symptoms of hypothyroidism, positive anti-TPO antibody, progressive increase in TSH, planning for pregnancy, and goiter, they should be treated. Between 7 to 9.9, treat with thyroxine to reduce risk of fatal stroke, coronary heart disease, CKD, and if they are young, less than 30 years of age, with some suggestive features of hypothyroidism. More than 65, consider treatment with thyroxine to reduce risk of coronary artery disease and CKD between 7 to 10. More than 10, treat with thyroxine to reduce risk of progression to overt hypothyroidism, heart failure, congestive heart disease, uh, mm, and CSD related mortality. So the message is very clear that above 10, we can treat everyone with thyroxine. Between 7 to 10, less than 65, only those who have comorbidities can be benefited. Between 7 to 10, without comorbidity, less than 65, only those who have, they should not be treated, and one can repeat the test. And if they have the comorbidities, they need to be treated. Between 4.5 to 6.9, anti-TP positive women, progressive increase in TSH, planning for pregnancy, and goiter. Between 4.4 to 4.4, treatment is not recommended, but only in women planning for pregnancy, one can again consider and keep the TSS less than 2.5. So I think I tried to pass it on to you, but I'm sure there might be more questions. So we can
Thank you.
take.
Thank you very much, Professor Singh, for an in-depth discussion on the therapy of subclinical hypothyroidism. But I know we can spend an entire day on this, but we have to be crisp, and you have brought it out. But we already have questions in the chat box. We will come to all the questions at the end. So we go over to the next topic, which is treatment of hypothyroidism across different ages. And to take us through this important area, we have none other than Dr. Manos Pratim Borua. The Ahom Kings, the last of the Ahom Kings was in, I think, 1826. But then we do have kings again in Assam, in Guwahati, and Dr. Manos Borua is amongst them in the field of endocrinology, in the field of overall medicine. So we welcome Dr. Manos, who is, of course, a consultant endocrinologist at the Excel Care Hospital and has numerous other accolades to his name. He's also associate editor of the IGEM, he's associate editor of Thyroid Practice, and so on and so forth. So it's over to you, Manos, to tell us about the treatment of hypothyroidism, how to tailor with age.
Thank you so much, sir. Thank you so much. It's a privilege to be introduced by none other than Professor Subankar, sir, who is our teacher. And it's also a privilege to follow Professor Singh, sir, who was also, as already described, teacher of teachers. So basically, my talk is going to be complementary to what Professor Singh has already dealt on. I'm going to talk about very practical points, clinical pearls about the treatment of hypothyroidism, how you titrate the dose, and in what age basically you choose what kind of dose and why. And it's a very important topic, usually not discussed, but I compliment our course director for choosing this topic. So just to give an overview about the treatment, the goal of treating a hypothyroid patient is to mimic the normal physiological levels and alleviate the signs, symptoms, and biochemical abnormalities. So, but then it's the one particular dose will not be suitable for everyone. So treatments will be tailored to the individual needs, and that's where the very important clinical decision making is important for the clinicians treating hypothyroidism. Of course, the treatment of choice, there is no controversy. It's levothyroxine. And of course, we have other preparations like desiccated thyroid hormone. And nowadays, we have T3, T4 mixture, which are not recommended. We don't have sufficient evidence that they actually, give the desired goals, help us to achieve the desired goals. So as of now, they are not recommended. So we only have levothyroxine. And levothyroxine sodium has a very narrow therapeutic range. That means if you do not titrate the dose carefully, you can push the patient into iatrogenic hypothyroidism or iatrogenic hyperthyroidism also. So we have to be careful, and we have to at least titrate the dose based on frequent THS measurements at the initial phase till the THS level is stabilized. That's why ACE recommends the use of high-quality blend preparations of levothyroxine, because it is known that there are clinical studies to prove that this, if you keep the thyroxine on a shelf for long periods, say after 2 months or so, the ability of a particular tablet to bring up the T4 level in blood, or free T4 level in blood, it disappears in some of the brands. So one has to be very careful about that also. And same brand of the levothyroxine should be given throughout the treatment period as far as possible. Then next question which comes to the clinician's mind is, what is the best time of the day to take levothyroxine? We all know that we usually give it in the empty stomach at least 60 minutes before the meal, and ideally that is the best, that is considered to be the best time. Of course, in some patients that may not be possible, and patient compliance may not be good if you stick to one particular time of the day. So in a limited number of patients, maybe as an exception, you can choose other times. So I have, on the right, in the right box, I have given you the list of if you put up the timing of the day, which is the best for the absorption of levothyroxine, it is just before breakfast time, and next would be the bedtime. So if you cannot give it before breakfast, the second option remains the bedtime, and 30 minutes before breakfast would come third. These are from the clinical studies, and the last one would be with breakfast, of course, which we will avoid for all practical purposes. And another important point is why we should give in the empty stomach 60 minutes before breakfast, because one, for some patients, the compliance may not be good, but most of the patients will have a very good compliance if it is given at a fixed time. The first thing to remember when you start your day, so this is the empty stomach. And there's a scientific evidence to tell us that THS variability is the least when it is given in the morning in empty stomach compared to when it is given in the other times of the day. And what are the factors which determine the levothyroxine dose required by a hypothyroid patient in reducing the THS level to an appropriate level? So there are many points which need to be considered, but today we are going to focus on the age. So apart from that, patient's weight, lean body mass, patient's pregnancy status, and planning the pregnancy or infertility status. Etiology of hypothyroidism also important. For example, chronic autoimmune hypothyroidism may not require that high dose compared to a person who was rendered hypothyroid because of ablative therapy after thyroid carcinoma or surgical therapy after Graves' disease, where there is no thyroid cell available to secrete. But in chronic autoimmune thyroiditis, you will still have some thyroid cells secreting some levothyroxine, so you may not have to go for a very high dose. Then next, of course, one consideration could be degree of THS elevation. Very high THS elevation may require higher dose, but again, that has to be titrated according to the patient's need, and that is not always mathematical or numerical. And in general clinical context, including the presence of cardiac disease, one must actually go slow and try to play a safe game, which I'm going to elaborate on after some time. So if you consider the body weight part, so based on body weight, hypothyroid patients would require, an adult patient would require about 1.6 to 1.7 microgram per kilo body weight, actual body weight. A patient may be obese, then requirement may be high. And in some studies, the requirement may even go up to 2.0 to 2.1. So you stand somewhere between 1.6 to 2, but mostly we consider 1.6 to 1.7 as a requirement. But interestingly, some other studies have also shown that the ideal body weight is the best predictor for levothyroxine dose. So even if you start with actual body weight and calculate the dose accordingly, later on you'll find that some of them have a THS very low, after 6 months or 1 year. So in those conditions, probably it's better to go back to the ideal body weight for that particular person, because it is a lean body mass, which is a better denominator for determining the dose of total dose required per day for any patients. And levothyroxine dose in thyroid cancer patients are usually higher, so that point has to be considered, and I will already mention this. Now, what are the age-related changes? What are the considerations which we must remember while choosing a dose, and what are the justifications? So, older patients required a lower levothyroxine dose compared to the younger counterpart. And one study that investigated females and males separately found that levothyroxine requirement with age was more pronounced. The decreased requirement is more pronounced in men. And declining body mass, lean body mass, in a male person, again, it's an important consideration which determines the lesser requirement of levothyroxine once the patient crosses a certain age and the aging process starts. Interestingly, sick patients older than 65 years with comorbidities would require lower weight-based doses of levothyroxine. So we may, and in a lot of elderly patients have so many comorbidities, and then once a patient starts having a significant comorbidity or different conditions affecting his or her health, then you find that the requirement may come down, and it is not surprising at all. And this could be a reflection of a physiological change, which we already know. That's called non-thyroid illness, where THS may be naturally suppressed without any primary pathology of the thyroid. And this could be reflected in the lesser requirement of thyroxine to bring down the THS to an optimal level in elderly person with significant comorbidities. So that point has to be considered. And what is the approach to initiating and adjusting levothyroxine therapy? So you can base your starting dose on the basis of serum THS level. And if you go for a full replacement dose, especially for adult persons like 18 to 55 years without a coronary artery disease, 1.6 to 1.7 microgram per kilo body weight could be the ideal dose. For subclinical hypothyroidism, which has been discussed in details by Professor Singh sir already, lower doses are required. It is safer to start 25 to 50 microgram, and then you go up or go down according to the THS level, and you may have different THS cutoff for different population, which has already been described by sir. And this conventional approach of giving the full calculated dose at the beginning is true for young and middle-aged patients without overt or covert CAD. That point has to be remembered very well. And usually we do an adjustment every 4 to 6 weekly based on the THS. That is the ideal situation. But of course, in some patients in our country, that may not be possible. The cost and patients' ability to come back to the clinic is also an issue. But then, as far as possible, we should be titrating every 4 to 6 weeks. Now, this is a very important slide. So in case of elderly patients with hypothyroidism, it's always ideal to start low and go slow. That's for the fear of precipitating cardiovascular events, and that has been documented. And in fact, in a patient with a known coronary artery disease, one can start with, once you start with a very low dose like 12.5 or 25 microgram per day, and then gradually increase at a quantum of again 12.5 to 25. It's no harm in going slow, bit by bit, rather than giving the full dose immediately. Then there are two other points which I want to mention here, is that even elderly hypothyroid patients who are free of cardiovascular disease, like proven by dobutamine test or bicycle ergometrics from clinical trials, and even if they are elderly, they may be given a full replacement dose. But then why don't we give it? Because again, studies have shown that uh, if we give a full dose to elderly person without cardiovascular disease, you can bring down the THS level. You can normalize the TFT within 12 to 24 weeks. But there was no difference in time which is taken for the hypothyroid symptoms to get resolved. That means the tissue hypothyroidism correction, it takes time in elderly patients. So even if you give a full dose, supposing the patient is not having any cardiovascular disease, then the patient still may have some hidden cardiovascular disease. So it's no point in giving actually. Even for all elderly patients, we should stick to the start low and go slow, irrespective of the fact that the patient may have overt or covert cardiovascular disease. Now, what are the exceptions in elderly hypothyroidism where you can go a bit faster? Patients who have been rendered profoundly hypothyroid by radioiodine therapy for thyroid cancer, or person who underwent thyroid surgery for Graves' disease, they can be given a little higher dose, and we can go for a quicker correction, because these patients were not having tissue hypothyroidism for long period. So their cells are acclimatized to living in a high levothyroxine level through the preceding period. So here you don't have to wait that long, and you can actually go a bit faster. Of course, again, the caveat is here again, if the patient is having coronary artery disease, it is the clinician's discretion. Again, I would suggest that one should be very careful in doing so. This is a bit of a busy slide, but I want to highlight few points here. What are the powers for adjustment of levothyroxine dose? What are the best practices? So with an exception of secondary or central hypothyroidism, where you can only use free T4 as a tool for adjustment, and rare instances of peripheral thyroid hormone resistance, again, a very rare disease, not usually encountered by clinicians, serum THS is the single and the best parameter which should be used for adjusting levothyroxine dose. And the adjustment should be made every 4 to 6 weeks, which I have already mentioned. And that is based again on a scientific fact, because the levothyroxine half-life is 7 days. And we all know that any drug requires about 4 to 5 half-lives to reach a steady state level. That means 7 into 4, just about 28 days. So within that time, there is no point in readjusting the dose. You have to allow that much time for the last levothyroxine dose adjustment to reach a steady state level. So after that, you can, of course, titrate. So before that, there is no point in titrating. And your target THS level may vary depending on the age and underlying comorbidities. And in general, increments of levothyroxine should be done in quantums like 12.5 to 25 microgram per day, because you never know at what point the critical level of levothyroxine is achieved. And even next 25 dose increment may actually bring down a THS of 30 to 5 within 6 to 8 weeks. So there is no point in looking at only the THS while increasing the dose. Like if you have a THS of 50 and you think that giving another 75 microgram per day increment will be good for that high level of THS, which may not be true. So it is better to again go a little bit conservatively and try to see how much of THS reduction happens in the next within the next titration period. And changes in levothyroxine requirement may occur with progression of thyroid failure, because in chronic thyroiditis there is a progressive failure. So there is no wonder that the dose requirement may increase every year or every 2 years or so, and you have to be ready for that. Aging, there will be lowering of dose, and pregnancy. Across the pregnancy, you'll find that the dose may be increased up to 100 to 150%. It's a huge increment of dose has to be done based on your quick titration or frequent titration. Changes may also occur due to many other factors like concomitant medications, altered absorption, and medication adherence, etc. This altered absorption is a very interesting topic. We can come to that while discussing, while taking the questions. And finally, patients being prescribed lower doses of levothyroxine appear to have more stable THS. So when you are in doubt about whether to go for a higher increment or lower increment, choose the lower increment, because studies have shown that if you do it in a lower quantums, the THS becomes stabler. You achieve more stability with the THS values in the subsequent period. So you just take a decision towards making an increment on a lower quantum. And why this is a very important. So just to describe it shortly, if you take THS as a function of age, you'll find that many of the elderly people have a higher THS level. So your goal should depend on the age. Your goal for an elderly person, your THS goal could be even 8 or 7.5. And beyond that, if you treat, probably you're going to do more harm, as so nicely elaborated by us, Professor Singh sir, just in the previous talk. But younger patients, you can come to this mean values somewhere around 3.5 or so. So tighter goal, or maybe in more intensive goals, should be set for younger population, and your goal should be a bit relaxed for elderly population, and middle-aged population you can put in between. And then coming to infants and children. So in congenital hypothyroidism, treatment with levothyroxine is a must, and usually it is done with a very high dose, 10 to 15 microgram per kilo orally once a day. And your idea is to titrate quickly every 2 weeks, and you want to achieve a normal THS level at least at 4 to 6 weeks, unlike the elderly or middle-aged population. Because if you delay the treatment, the cost of impaired neural development, the irreversible neural damage is going to be too high. So here the situation is completely different. Approach is completely different. You are very aggressive and you are using a very high dose. And of course, a young heart will not supposed to have any underlying cardiovascular disease. Talking about in children, starting from 1 year to 3 years, your dose is coming down from 10 to 15 to 4.6. 3 to 10 years, 3 to 5. From ages 10 to 16 is 2.4, and above 17 years is the adult dose. So it's very interesting to observe that with increasing age, your requirement is going to come down gradually, and you're settling somewhere around 1.6 to 1.7. For both forms of hypothyroidism, the dose is titrated to maintain serum THS level within the normal range for age. So a clinician must be aware of different of the impact of age on the THS range, and which I have already mentioned that younger age will have a lower range and elderly people have a higher range. For children, thyroid replacement should be given only as a tablet, and which can be crushed and made a paste into the infant. In fact, in children, we put it inside a slice of banana and allow the child to swallow it, because most of the time they refuse to take, and it becomes a very difficult problem for the parents to give, especially in congenital hypothyroidism, which is a life-saving drug. So these are important points. While monitoring infant and children while giving levothyroxine, one must remember that they should be monitored more frequently during the first few years of life, because growth, development, especially neurocognitive development, depends to a large extent on a proper levothyroxine level in the blood. So it should be done every 1 to 2 months during the first 6 months, and every 3 to 4 months between 6 months to 3 years, because after that, usually the neurocognitive dysfunction can happen only below 3 years. So this is the crucial period where you have to be very careful and very attentive, and you should follow up the patient more frequently. Later on, you can follow up just like elderly people, adult persons. During pregnancy, THS should be kept at a low half, as it has already been mentioned, a bit controversial though. One target could be less than 2.5 if you're treating a pregnant lady with levothyroxine. Of course, recent guidelines have said that you can keep it somewhere around 3 to 3.5 depending on the population where you're treating, but 2.5 or 3, but at least it's not 4.5 probably if you're treating them. And your frequency of monitoring could be 4 weeks until mid-gestation, and after mid-gestation, at least once near 30, because till mid-gestation, there is high risk of placental abnormality and abortion, etc. So how and why levothyroxine requirement changes during pregnancy? Because there are various theories. T4 pool must increase by approximately 40% to 50%, and most of it is going to get converted to reverse T4 in the placental in the placenta, and we don't yet know what role reverse T3 plays, but it could play some important role. Moreover, clinical studies have confirmed that the increased requirement of thyroxine or levothyroxine occurs at earliest 4 to 6 weeks of pregnancy. That's why it is advisable for patients who are planning pregnancy to be careful and to increase the dose and to keep the THS level at the lower, half of the normal range. So treated hypothyroid patient of reproductive age should be counseled regarding the increased demand of levothyroxine during pregnancy, and they should be counseled to contact their caregiver immediately upon suspected pregnancy. And they can actually increase the dose by 20% immediately when they come to know about that pregnancy. Confirmation comes about a pregnancy, and the goal is to keep the THS level at 2.5 or maybe 3 for some population. And this is the crucial pearl here. The requirement can be increased immediately by 20 to 30%. And one simple way to do without calling the patient to clinic is to ask the patient to take 2 extra tablets of the same dose for every week. Like a person is taking 7 tablets in 1 week throughout the 7 days. Now we can ask the patient to take 2 tablets on 2 particular days. That means 9 tablets in 1 week, and that usually gives you about 25% increment of the pre-existing dose, and that should suffice for most of the patient during the first weeks of the pregnancy. And then of course you will monitor according to the THS level being done every 4 to 6 weeks. I mean, at least 4 weeks is the best thing for pregnancy, and that should be followed. And after pregnancy, that there is alteration in the levothyroxine requirement. During follow-up, you will find that the requirement might come down. So in some patients who were requiring only very low dose of levothyroxine and who were diagnosed for the first time during pregnancy, they may actually become euthyroid and they may not require any levothyroxine, and that should be assessed somewhere around 6 weeks after pregnancy. That reassessment-wise, if there is no requirement, there is no need to give. So it's not a lifetime disease, because pregnancy, because of increased demands, there could be a subclinical hypothyroid state which may not last longer throughout the life of the patient. Of course, a patient whose requirement was say 100 microgram before pregnancy, and at the end of the pregnancy you find that the patient was requiring about 175 or 200 microgram. It is not that the same dose will be required during the lactation period. The requirement is going to come down, and that should be kept in mind. And usually we go back to the pre-pregnancy dose which was given just before the patient become pregnant. That's the usual protocol which we follow while following up a patient during the lactation period. So with this, I end my talk, and I think I have opened a lot of queries in your mind. And with the permission of the chair, I think we can take up the question. Thank you very much.
Thank you very much, Dr. Manush Barua. That was a really wonderful covering a lot of ground. So we do have many questions. So let's open it up. And we have a question by Dr. Satik Siddhanto. He has got a couple of questions. One is directed to Professor S.K. Singh, who suggests that can we do just the TSH for diagnosis of subclinical hypothyroidism? Does the patient need to spend an extra amount by doing also a T4 or free T4?
Yeah, yes, we can go for TSH assay, but if the TSH value is more than 20, it's quite possible that patient would have low T4. So if the TSH is less than 10, we don't need to go for T4 assay to confirm. But if it is more than that, we definitely need to know what has happened to T4. If T4 is low, then the normal range, it is overt hypothyroidism. And overt hypothyroidism is possible when TSH crosses beyond 20. Between 10 to 20 is a just matter one can think of, that perhaps this case is going towards overt hypothyroidism, and less than 10 you don't require. But mind it that many times the TSH value is also not very correct by most of the laboratories. And the TSH sample taken in the morning, taken empty stomach, taken after meal, taken in the evening, that will also affect the exact value of TSH. and therefore we need to have these two paired values to actually validate the laboratory analysis of TSH. We can ignore it if the cost is a matter. We can ignore it and just we can depend on TSH. Yeah.
So the only issue there is yes, Vanush, you wanted to comment?
Yes, I think so. You're trying to talk about bioinactive assay in pituitary hypothyroidism. It's a rare condition,
Yes.
but then
Yes, central hypothyroidism.
Yes.
That's an area where we may have some difficulty in understanding. Yeah. So the other question, Dr. Siddhanta has actually asked a few other questions as well. One, I'll just find out. Yeah, that's also an interesting question. Maybe Manush, whether you would like to take this. And we have a related question. So two patients, A and B, of overt hypothyroidism, weighing, let's say, 50 kilos. One has a TSH of, let's say, 15 or 20. The other has a TSH of 100. So should the starting dose of levothyroxine be the same? Let's say 1.6 microgram per kg body weight.
Yeah, I will prefer this, sticking to the upper limit of 1.6 if the patient has got primary hypothyroidism due to chronic autoimmune thyroiditis. That it
So in other words, does the TSH level at all determine, or it's just the body weight? You did show in your schema of things, TSH level as also a factor that could determine the dosage.
Yeah, there are some studies to show that, but in case of overt hypothyroidism, we go for a full dose, but whether we go for a full dose immediately or in a staggered manner, that's a different issue. If the pre-T4 is normal, then if of course the THS cannot be more than 50 when the pre-T4 is normal, I have to get a repeat THS test done. And if it is, suppose pre-T4 is normal and THS is even 30 also, then of course I will go for a lower dose and treat that patient as subclinical hypothyroidism, because there are so many confounders in the assay of THS, which sir has already mentioned, heterophilic antibodies, etc. So then in those situations, my free T4 will be helpful.
Right. Yeah. So, but at this point of time, based on TSH, especially in overt hypothyroidism, possibly we do not have specific guidelines, though in our minds we may sometimes, as you've already said, that the failure of the gland may be progressive over a period of time, and someone with a TSH of 100 may represent maybe more sub-functioning gland than a TSH which is not so high. So there may be logic to that, but by and large we don't follow that. And interestingly, we have a proposal currently. We have just taken it up from IIT Kharagpur to do a mathematical modeling around the dosing of thyroxine in hypothyroidism. So we're just setting that study up. So there's a related question. Maybe shall we go back to Dr. S.K. Singh? Yes.
Can I just give a comment?
Yes.
The suppression of TSH by T4 actually doesn't follow that arithmetical factor. Like if we double the dose of thyroxine, it will halve the TSH. That doesn't follow. Yeah. And therefore, if the TSH is 50 or 100, doesn't make a difference in choosing the dose of thyroxine replacement. But if it is subclinical, of course, you have to give very small dose. But if it is 50 and 100, you do not follow anything regarding the dose. And still the dose should be the same, whether 50 or 100 or more than 100.
Sir, if I may, it's one point here. There is one exception probably in myxedema coma. We give very aggressive dose. So the conventional teaching is giving high dose.
There the reason is that they have TBG circulation, and unbound TBG needs to be replenished with thyroxine first, because whatever thyroxine you give will go to TBG to saturate it, and after its saturation, only the free T4 will be available to the tissues. So that is a different condition where we need to give very high dose just to block the TBG which has been unoccupied because of very low level of T4. So once you saturate it, then you give maintenance dose
and
as
mixed
usual.
edema, mixed edema coma is also not diagnosed or based on the TSH level.
Yes, sir. Yeah.
This is more a clinical condition.
Clinical diagnosis.
Yes, Professor Singh, you just mentioned that we give a small dose for subclinical hypothyroidism. So Dr. Abhik Das really wants to know, how do we calculate the dose for thyroxine in subclinical hypothyroidism?
Usually the dose ranges from 25 microgram to 50 microgram in subclinical hypothyroidism, whereas 1.6 to 1.75 microgram per kg body weight in overt hypothyroidism. So in subclinical hypothyroidism, usual dose is 25 to 50 microgram. That has been a conventional practice by all of us. But sometimes very obese people may require slightly higher dose or even higher dose. And some of them actually do not get suppression of TSH even if you increase the dose to overt level. And it is said that perhaps they have the set point for, or the threshold for TSH suppression is set very high, and therefore they have a little high TSH all the times, and it is difficult. It is a kind of a resistance at the pituitary level to thyroxine. And in those cases, you might even induce thyrotoxicosis, and yet they do not have complete suppression of TSH. So these are the peculiar situations. They do not commonly encountered in clinical practice, but then the lower dose is to be started for subclinical hypothyroidism, and most of them will be benefited by up to 50 or maximum up to 75 microgram.
Yes, so around 50 or thereabouts. Yeah. So there's a question from Dr. Sundar Rao. Maybe Dr. Singh once again. That's a lady around 35 years, presents with repeated miscarriages, TPO antibody positive and TSH 4.5. Should she be put on thyroxine to improve her pregnancy outcomes?
Yeah, I just discussed that the anti-TPO positive, and some of the studies have shown that TPO positive cases should have TSH less than 2.5. So they need to be treated, and most of the guidelines, ATA, the British, Brazilian guidelines, they all recommend that they will be benefited by treatment. However, in the studies, there had been conflicting results that treatment would prevent fetal loss in these patients who are anti-TPO positive and TSH of less than 2.5. But definitely they have correlated with the overall outcome preeclampsia, and they have shown that incidence of preeclampsia were less, so they need to be treated. So we also recommend that anti-TPO positive, TSH more than 2.5, they need to be treated. Anti-TPO negative, TSH more than 4, they need to be treated.
Right, and so that's a related question Dr. Neha Agarwal asked. So this is a lady, Manoj, if you could take that up. Lady in first trimester, TSH 5.5, TPO antibody negative, and doesn't have that adverse pregnancy outcomes, history of adverse pregnancy outcomes, bad obstetric history in the past. So shall we start this lady on thyroxine? First trimester, TSH 5.5, anti-TPO antibody negative.
With a bad obstetric history.
No, this lady doesn't have. Maybe this is the first pregnancy.
It's a very difficult question because there is no antibody titer has been given. I'll try to find out.
It's negative. Antibody is negative. Yeah.
But personally, in my clinic, it's a 5.5 I'm treating, and I'm not over treating. I'm trying to keep it somewhere around 2.5 to 3.
Right.
I'm doing no harm.
Yeah, absolutely. I think that's the response from most of us.
Yes.
Yes.
We all agree.
So we should treat and
we should treat.
Target for a TSH about whatever. So of course we do understand that the ATA, the American Thyroid Association, the last recommendations 2017, partly because of pressure from publications from across the world, including from our own country, multicentric studies, which have suggested that the TSH levels are really not that tightly maintained in pregnancy or in every woman. 2.5, that not every woman has a TSH less than 2.5 in the first trimester. So they have actually now accepted pragmatically that the TSH, if you have a pregnancy specific cutoff for your region, then follow that. Otherwise, maybe mostly it's about 4 is taken as a cutoff rather than 2.5 for your decision making. Yeah, so that's good. And then there's a question again, maybe Manoj, if you take this from Dr. Satvik Siddhant once again, your comments about once weekly thyroxine, because you said the half-life is so long. And
Absolutely, yeah.
So why do you give it every day? That's absolutely illogical.
The everyday thyroxine, you had the thyroxine preparation to start with as a everyday pill, and we had in between, we had once a week pill also, and it is possible to give once a week. The problem is, if you expect your patients for chronic lifelong disease to forget his daily pill, there is also a possibility that he or she might forget that 7th-day pill. That has happened to me and my patients. They keep on forgetting that 7-day pill. I mean, that means the entire month they are without thyroxine. So that kind of problems are there. But otherwise, if your patient is compliant and she or he is more compliant with once a week therapy than the daily therapy, I can go ahead with that. There is a preparation, I guess. I don't know whether it is going on now.
Whether it's still available, I don't know. A number of companies had come forward.
But sir, another point I want to tell you. One is that you may simply forget that once a week tablet, and the entire month, 2 months, you are without it. Another point is that some patients may be confused and they take it every day. That means they are taking 7 times the prescribed dose. That has also happened to my patients. So I nowadays stick to the conventional therapeutic, protocol. Give once a day, whatever dose. Sometimes I give 2 tablets on one day just to up titrate. That can happen. But otherwise, mostly I'm giving once a day. So there are inherent limitations of giving 7-day treatment. No?
Once a week.
Is available. Thyro week is available once a week preparation. But fundamentally, I think this should be discouraged. The reason A, that when you give very high dose at once, at least it is bioavailability is 60 to 70%. So if it is absorbed, it goes into circulation, and there will be some immediate effect of this high dose of thyroxine. It's been observed that people who are taking their tablets, they have some problem in sleep. So if you are taking tablet in the night, you may have little disturbance in sleep. And this has been correlated with the high circulating level which exists during first 4 hours of taking the tablet. So if you're taking such a high dose, and every 7th day you will have problem at least on day 1 or 2 because of very high level. T4 has also axon, and it is 1/10 of the axon of T3. So if you have very high level suddenly going into circulation at once in a week, it is not physiological. The physiological would be that much being produced by the thyroid gland. And therefore, I think this is 1.7 microgram per kg is the physiological replacement, and it gets converted in T3. It appears more physiological, and weekly regime is unphysiological replacement of thyroxine. So I'm against that, and I've never used it, though it is available.
Right, but I don't understand. Why do you say it's unphysiological if the half-life of levothyroxine is 7 days, 8 days?
Yeah,
so it should be given no more frequently than every week.
Half-life.
But the practical point Dr. Manoj Borua has raised, I'll come to that point soon. That is important, of course.
Yeah, that's good. But then half-life this relates to the availability of thyroxine in circulation. It means that the level is maintained in circulation. However, when you are giving once a week, then you are stacking the dose in your body. So 7 days dose, which you have been giving every day, now you have stacked it, and that will have its consequence. We are not going to address that consequence. We are just saying that it will be cleared off in 7 days, and within 7 days, the level will be maintained to that which is maintained by taking every day. But then this stacking effect will be there of
Right.
having high dose in circulation.
Right. So, yes, Manoj.
Yeah, after steady state, actually stacking may not be that important, but then but I will rather buy the other point which Sir has so nicely elaborated. In the first 4 hours, we are giving them. I mean, we don't know about the entire action potential of a particular molecule. We're just thinking that it's going to get converted to T3 at a tissue level or liver level. So the first 4 hours would be very important. And why add to the agony of the patient? I mean, if the patient is not comfortable. But my point is, if the patient is not at all willing to take a daily dose, and for that his treatment is hampered, probably in those patients, this is an option, not as a routine option, but as an exception.
Right. So, yes.
And this is not drug actually. I don't call thyroxine as a drug. It is a hormone and there is a deficiency of this hormone. So we are replacing it. So this should not behave like a drug. It will have some effect, even if it is not. Yeah, that's very important issue. Actually, they don't.
Right. Yeah. So coming back to Dr. Manoj Pratim Borua's issue of compliance. So what he said, if the patient is not compliant, then once a week is not the way to go. I would say that I have had occasions, not this Thyro Week or these preparations that are available ready-made, but I have had issues of using once a week thyroxine in certain instances where I found that the patient could not be relied upon to take the tablet regularly. And so what I had done was to entrust someone, maybe it was an elderly lady in the family. Yeah. So have the son who is available on a Sunday. The other days he rushes off to office. So I have asked him to administer those under supervision once a week. And sometimes that has worked well. So in case of non-compliance, I have used once a week in certain cases under supervision.
So for that reason, you can also advise them to take 4 tablets or 5 tablets of thyroxine. Thyroxine at once.
That's what I've done.
That we have been doing in the past also.
Right. So we have to wind up. We already passed our target. But Dr. Manoj, we have a question from Dr. Sundar Rao. It's very important, but not. So how to diagnose hypothyroidism in neonates is what he has asked. So maybe what should be done? Should we wait for symptoms to appear and then?
No, actually, in many countries we have that neonatal screening program, which of course we are yet to have in India. So I don't think in neonatal outside this neonatal screening program, only one reason why you do test, routinely test without waiting for the symptoms to appear. The thyroid function you will test only when you are suspecting neonatal thyrotoxicosis, which can happen in a Graves' disease patient, advanced Graves' disease patient will getting treated till the last trimester. That's a different issue. Neonatal thyrotoxicosis is a transient condition where it remains for 7 to 10 days, and after that the patient is recovered. Otherwise, probably it is a pediatrician's assessment of neonatal, symptoms and classical symptoms of umbilical hernia, constipation, and failure to thrive, prolonged jaundice, and hypothermia, etc. will count. I mean, otherwise we don't have a routine screening as of now. So without symptoms, so how I don't think I can suggest that we should screen each and every child for hypo, because many times what happens, you have a THS level of 12 or 13, and I get referral, and the parents will bring that 7th-day-old child to my clinic waiting in a queue just to show a THS of 12, which is actually normal. You can repeat it next week, it will become normal. So there are so many issues of over-diagnosing the cases, unless we have a universal program of neonatal screening. So I think I will wait for the symptoms to appear, classical symptoms to appear.
Here again, I think the contrary argument would be that unless we do our universal screening, we will be missing out starting treatment late, and we are all aware that thyroxine is so critical for developing the synapses inside the brain and for brain development. So though the prevalence may be not very frequent, so maybe, and in our country there is some evidence maybe it's somewhat more common than in some other countries. So I think the way forward is definitely to have a universal screening program, and I think at least in the private setups, in most cases these are being done. In the government setup, it's not still part of a routine procedure. But probably that's what we should do. We should be waiting for the symptoms, because the more delay you have in starting thyroxine, the less can you have a normal IQ in adult life. So, of course, that's a decision that the government, the society has to take. But
Yes.
In our practice, we should encourage, I think, universal screening. So I think we have had excellent talks, and we have very good discussions. And it's so encouraging to see 900 doctors coming on and being part of it. And it's because of Dr. Manush Borua, because of Dr. Singh. They have come to learn,
Because
to
of you,
listen.
sir.
And hopefully they take back important lessons that they can apply in their clinical management of patients as well. And I personally would also like to suggest, and we have senior members of the endocrine firmament in our country, that I do not like the term subclinical hypothyroidism, in the sense it gives you a false notion, because the diagnosis is not based on anything clinical. Diagnosis is just biochemical. So I would prefer the term a biochemical hypothyroidism or something like that. The subclinical is absolutely a wrong notion, and I think we should be writing to whatever and to various bodies and trying to get this nomenclature changed. And because many of them could have mild symptoms, but still we call them subclinical hypothyroidism. So with this note, once again, thank you very much, Professor S.K. Singh. Thank you very much, Dr. Manush Borua.
Thank you, sir.
Thank you, Team Intas Zenith, for providing the platform. And thank you very much, all of you 900 plus doctors around who have shown the interest, and we do hope we have been able to be of some help in your clinical practice. Over to the organizers.
Muhammad sir, on behalf of Hintas Zenith Division, myself, Mudit Prashant, General Manager Marketing, extends vote of thanks to our eminent course director, Dr. Shwanka Chaudhary. Dear sir, without your able guidance, we could have not done this 6 webinar in a series of practice person endocrinology. I'd also like to thank our esteemed faculty, S.K. Singh sir and Dr. Manush Borua, for a very interesting and informative deliberation, and of course, very interesting question answer session, sir. It's also a pleasure to inform that in TASK, we have launched TASK, which is a patented research formulation of thymoquinone that will help fight the infections and could be add-on to the standard care of COVID-19 management. Sir, we have also launched dapagliflozin at a very affordable price. Dapavel 5 milligram is just 9 rupees 90 paisa a day, and Dapavel 10 milligram is only 11 rupees 90 paisa a day. So I will request delegates to please join the 7th edition of the program, which will be scheduled on the 3rd Saturday of the December, that is 19th December, at the same time. And I would like to thank all the eminent faculties, all the delegates once again. And I would also like to thank the technical team who is at the back end for this very good support they have provided to make this program successful. Thank you, sir. Thank you, everyone.
Thank you.
Thank you so much,
Thank
sir.
you, and good night. Good night to everybody.
Good night, sir.
Subankar,
Good night.
good night.